we intro the papers. Can you give a brief intro on your background, where you currently are, and then we can dive in?
Yeah. So you mean like where I grew up, long walks on the beach, that sort of stuff, or like more like pertinent to what we're after?
You can do both. Totally up to
Okay.
you.
Maybe the more relevant piece, I guess, is maybe based more on my training. So everybody's got to go to undergrad before they go to grad school. So I checked that box. Went to a small school in PA, Lock Haven University, way up in the mountains. I grew up in a small country town, so that's kind of my background. Then went off to a big place called Duke, and learned from some really smart people while I was there. Came out, worked with an orthopedic surgeon, he and I hand in hand, who was the former director at Duke Sports Medicine, and we had a sports medicine shoulder clinic where we saw primarily folks who had shoulder pain for a majority of the day and for about 10 years. During that time, also worked on my PhD. When I was finishing that up, I then did a faculty residency, 2-year faculty residency at Duke, just because I didn't feel like I was done quite yet. And then transitioned out here to University of Indianapolis just about 3 years and change ago, probably. And so that's where I'm at right now.
Perfect. So I reached out to you initially because this was Shoulder Month, and I initially talked about kind of the Viewpoint paper you were on with Jeremy Lewis, and then we also will look at the systematic review on subacromial decompression. But as you said, I think the Viewpoint maybe we'll have a longer discussion, so we can start there. So do you want to intro kind of why you and Dr. Lewis created this Viewpoint and a little background on it?
Sure, yeah. First, I gotta say I feel a little overdressed. I didn't know like sun's out, guns out, and all this stuff, but I feel like I've got button-up shirts with the sleeves cut off. I could go get one quick, but
You can switch into a tank if you want.
okay, I might. We'll see how this goes. Yeah, so the Viewpoint that Jeremy Lewis and I wrote, kind of, and I don't want to say I came up with the idea, but that's what he says. But he and I began to kind of work together on a few projects, and I was interested in doing a Viewpoint. I think JOSPT has kind of created a very nice avenue. So it's smaller than an editorial, and it's meant to be a little kind of, I don't want to say edgy, maybe is not the right word, but to kind of get folks thinking, a little controversy, a little, hey, this is how we've done it, but maybe we need to be better, sort of a deal. And that kind of fits my MO. So I thought it would be nice to write a Viewpoint. I love the shoulder, and I hate special tests for the shoulder. And so I thought it was a good fit to go ahead and write something along those lines. And so I asked Jeremy if he'd be interested, and he was all in. And so I can remember it was probably, golly, well over a year plus ago. I was in China. I go over there for a couple weeks to a month every year to teach physician residents and things out there with a program from University of Southern California. And so we were kind of back and forth at that time, beginning the process of formulating ideas and coming up with how we can best present this to be true to what it is based on where the current evidence is, to be impactful, a fun read, and also give clinicians something to take away, right? And not just put this idea out there that these special tests aren't on a great foundation anymore based on the current evidence. But even without those, here's what the current evidence suggests a shoulder physical exam, subjective exam should look like, right? And that's what that box is in that Viewpoint. So that was all Jeremy's idea. We were writing this and we were coming towards the end. He's like, we're going to need, so he said, Claire Arden, she's the editor-in-chief of JOSPT. He's like, she's going to need or want something that's going to be, something that we're going to kind of put in place of that. If this isn't it, then what is? And so it was his idea to create that table, and we did. And that's probably something I really like, a takeaway. If people were to say, what do you want folks to take away from this article? if you read the abstract, you miss that table, right? And I think there's a fair bit we can take away from that article, but that table I think is helpful because I think people look at this and they say, hey, you know what? These special tests I've been doing for years and I've had good success. And I'd say, first, tell me what success means to you and how often did you follow up with the patient 2-3 years after that? Or is it your own anecdotal experience that you did well for that patient? And then the other piece is, I just, yeah. So I think people get hung up on a few things if they just read the abstract. And it's not that we're trying to take this away. We're just trying to take the evidence where it's currently at and say, here's what we've got for what we think currently might be the best way to go about looking at someone with shoulder pain. That's a lot of talking. I'm sorry. I'll stop.
After this was published, was there much pushback with receiving conflict, or within like maybe when you're at Duke or when you're where you currently are they still doing these type of special tests? And does that kind of mess things up a little bit?
Yeah. I think, anytime you put something out there like this, you got to know and you got to expect and kind of you got to be loaded for bear because they're going to be coming at you. And that's fine because at the end of the day, that's not what I'm interested in. I'm interested in driving our profession forward and helping our patients the best that we can. And, I think we can get into this wherever we get to, but I think there's actually harm if we put too much weight in these special tests. And you might think it's a special test. How can that be harmful? But I think if we follow the narrative and plug in the special test result to that and perseverate on a biomechanical or structural reason for the pain, and that the only real way to fix that is surgery, and surgery carries, there's this whole cascade that we can kind of play out right in different scenarios that I've seen in clinic, and I think others have too. So yeah, certainly a lot of pushback, a lot of controversy, a lot of, well, you're not proposing we do that here. And I'm like, well, I'm the one that teaches that content. So, we'll see, right? It's yeah. So yeah, fair bit of controversy. I'd like to think that it was pretty well received by most folks, but you'd be foolish not to think that people aren't going to push back on this quite a bit. And some of you might too, and I really welcome that because, heck, this is where we stand now, but maybe 2, 3, 5 years from now, somebody writes a viewpoint refuting it based on the current evidence then, and that's great. That's what we should be doing, right? So please make no mistake, I'm not out here promoting my own, whatever. I'm just taking what a lot of smarter people have done, packaging it and putting it out there.
Yeah, I really liked just this one section. It's sort of like a clause. It's like, given the current evidence, like this is what we recommend, but that's just based on like what's out there right now. And definitely open to it changing in the future, just depending on the evidence. I really appreciated that part. And then also Dr. Lewis putting the, chart down there at the bottom, just as like a PT student, like without that, just all those like false gods that are torn apart with like all these special tests, just not coming up that great. What did I have to, draw from? And I thought that chart at the end was really helpful.
No, I appreciate that. And I think we've got to take that approach of being willing to continually ask ourselves, do I need to, is my thought process and what I'm thinking or how I'm treating this patient population or whatever, is it time to change my approach based on new evidence? We have to continually be asking ourselves that question and being okay with the answer and changing, right? I think that's life, right? Not just PT, I would hope.
And Dr. Salamh, where did your original like skepticism with like special tests begin? Like obviously, I don't think just one morning you woke up and just hated them. Like what was the kind of like the kickoff for that?
Yeah, so I'm gonna have to ask you to repeat what you just said because I just seeing this stash like right in my face and it's mesmerizing. No, I'm kidding. So good on you. I like it. It's a strong stash game. I think where it came from for me, I was I was very fortunate to be taught by two incredibly wonderful people and smart people, Chad Cook and Eric Hagedis at Duke. They taught my musculoskeletal curriculum. So, I mean, how much better does it get than that, right? And so there was always this sense of sort of, don't believe everything you read. You know, you've got to be critical and analyze, and that was kind of already in my nature, and so it just fed into that. And I developed a love for the shoulder. I developed a love for research, and I developed a love for sort of following what was, I don't want to say true. That's a bit sort of philosophical, but you know, if we have current evidence that breaks down the foundation that 17 things stand up on, then those 17 things got to fall, right? It's like pulling a pin in a grenade. That's the end of that, right? You can't continue to hold on to that. Otherwise, bad things happen. And so I think for me, where I became passionate about it was seeing young clinicians and my students going through a very thorough, thoughtful physical examination for the shoulder, getting down to the section of special tests, performing one or two special tests and letting that change their mind, that they had already sort of hypothesized what was and came up with a good plan for the patient. And because of a positive or negative on a special test, they began to question themselves. And for a young clinician, I wanted to see them build confidence in their abilities to perform those pieces of the examination, come up with an idea and a plan. And when I saw them throw all that hard work out the window that they just spent 30, 45 minutes on for a 30 or 45-second special test, that just rubbed me the wrong way to no end. And because I want them to be successful and I want them to build their confidence. And I felt like that was it just wasn't right. And so I had been not performing special tests in my own clinical practice for a long time, but where it really became sort of a gritty piece for me was I don't like how this is not helping my students develop well, or as well as I think they could, if that makes sense.
Yeah, could you provide like an example where you would see like what they would specifically change? And obviously I'm sure it would go all over the place, but like, and I know you mean like, okay, then they get a positive empty can and then it just completely changes. Like, what would you see that was just like, oh my goodness, why did that change so much?
Yeah. And I can give you a couple examples. You know, I think part of this goes a little deeper than just the result of a special test. It goes to the physical therapy diagnosis we posit based on that potentially, right? And then we think that our treatment is then somehow going to be directed by that. And maybe that's true if you've got something that increases your, you know, post-test probability a little bit or things like that. But I can vividly recall, and I even took a screenshot without any identifiers, not a screenshot, but a little picture on my phone, without any identifiers of a clinical examination where they performed 9 different special tests from all kinds of different categories. And all that tells me is that you got no freaking clue what you're looking at, or you're not confident in what you thought was it, because now you're just searching, right? If you're doing tests for a labral tear or cuff tear or subacromial impingement, instability, if you're just doing all these tests just to see what pops, one, that's not good clinical decision making. And two, that kind of goes back to my earlier comment about where and how you're developing as a clinician and what you're letting set the stage for your treatment plan for the patient. And at that point in time, what that tells me is you're letting that influence you a little bit more than the other pieces. And so make no mistake, nothing's perfect, right? Absolutely nothing's perfect. And when you look at a physical examination or your entire examination, all the way from your subjective down through into your treatment, you have that shared decision-making conversation with the patient. The exam there's no one piece of the exam, I think, that outweighs another. It's the culmination of your findings throughout the exam that give you what you're after. Sometimes in class, I'll liken it to making soup, right? And as you're going through the eval, you're taking the ingredients and putting it in the pot. You have no freaking clue what the soup is until you're done and you've got all the ingredients in the pot, right? You could be cooked carrots, celery. I don't know if it's potato soup, chicken noodle soup. I have no idea yet until I get all the way down and I'm putting all the pieces in the pot. Then, but it's not that one ingredient's any more important than another. But if you start throwing things in there that don't belong in the recipe, that screws things up. So.
Awesome. Thank you.
Yeah.
One thing, oh, go for it, Derek.
I was just going to build off that a little bit, because I know in school, we just got done with our orthopedic evaluations, and we had to know every special test, what it was tested for. And I think the hard part is that they perpetuate that, you're only going to have 10 or 15 minutes with this patient. You got to get them in, you got to get them out, and you have to know exactly what you're dealing with. When really, I think, based off of a lot of these papers and different topics, like, we need to be more comfortable with uncertainty as far as what specific tissue might be involved, and be more comfortable with actually addressing the person in front of us, like you kind of mentioned, and trying to get to understand who they are and what's going to benefit them. So, not necessarily giving them a specific diagnosis, but letting them know that, natural history plays a big part in this. We know there's a good prognosis, and essentially, regardless of what this special test tells me, doesn't tell me what the specific tissue is, it's not going to change my approach to treatment, and we're still going to see good outcomes in the end. But I think that's hard, because you try and have that approach in school and they shit all over you, because it's like, well, no, that's not how you do it. And it's like, well, I mean, I understand that you were taught this, but at some point, we do have to kind of move on from that. So I do think that there's a lot of cognitive dissonance, at least from my education in chiropractic. Now, of course, there are some good things, so I don't want to, say that everything's bad, but.
No. And I don't think we're taking that away from it. I don't think you would probably be the voice of a majority of PT students across the nation, right? That's probably the narrative when we speak about special tests, right? And you don't have to look any further than the shoulder to see, 70 plus special tests. And if you look at the different variations, you're up over 100. And anytime you got that much stuff going on, it's like you're just throwing stuff out there, right? And so, yeah, so therein lies the problem then, right? So, if that's what you're being taught, and then you go out, and the demands of clinic right now are ridiculous. Even pre-COVID, back when masks were, used for Halloween and robbing banks, and that was it. We used to, be able to see patients in person and have more conversation and time with them, and that sort of thing. But there are certain demands and productivity, and don't get me started on that conversation, because that shows me your emphasis is on something else, and it's not the patient. That's for sure. Yeah. So smart folks like you recognize that, right? You recognize that doesn't fit where you're at. So you humbly bow and you do what you're supposed to, and then you're able to go out and practice and be a good consumer of the evidence. But what about those folks that don't, right? Let's say there's 50 for every 5 that don't, and then they have students that go to them in clinic, right? And so it just kind of perpetuates that cycle. And so if we don't push on that and try and break that, then it just carries on. And we talk about that in the article, where we have that section of why they keep doing what they're doing, and we give those 3 reasons: simplicity, teaching old clinicians new tricks is kind of what you're talking about, and then teaching new clinicians old tricks. And so we put that in there on purpose, because we wanted to try and hit it at every level, right? This isn't just for clinicians who are going out there. These are the people that are being educated, and we got to stop doing it, because if we don't stop there, it's just going to keep going. There's some stuff here in this chitty chatty box. Let's see. How does a clinical evaluation look like without special test? I would refer to table 1, but we can get into that. We'll get into that. And then table. Oh, Chris already handled that. He says, "Hey, Bert, do this thing." Good. Okay, great. Okay, thanks. All right. So I didn't even need to do that. Sorry, that was a waste of you'll never get those 45 seconds back. That's my bad. Carry on.
So I actually had a question when you were going into the special tests, and as a student, say something shows up and then it just trashes all what you've had before as far as like your hypotheses go and everything like that. And in the way it's been like taught in our lab classes, all right, you've got a primary hypothesis, you've got a secondary, maybe a couple secondaries sort of thing. And with the uncertainty that surrounds like special tests, would you say that using one or two of them to sort of guide, do you think that even special tests are appropriate to sort of guide you one way or the other as far as like a primary hypothesis or a secondary, or does that even really matter that much?
I don't think so. I kind of see where you're at, right? So, you're thinking, okay, you talked about how much emphasis sometimes can be put on that, but what if we dial that down a little bit and we say, all right, here's our primary, here's our secondary. We do one or two special tests to help us maybe formulate or rule out take a hypothesis off the table and focus more on something else. Is that kind of what you're after? Kind of turn the dial down, and I think there shouldn't even be a dial. I think it shouldn't even exist, and that's just me. And I also want to be clear too that this isn't all special tests ever made for the shoulder. These are rotator cuff related shoulder pain special tests, right? Or orthopedic physical examination tests. So, it was a great viewpoint by Eric Hegedus and a few other folks about, hypermobility of the shoulder earlier this year in JOSPT. And they talked about, some of those hypermobile, shoulder tests and how that, and then in addition to other pieces of the clinical exam, can help them formulate hypothesis about whether it's hypermobility that's feeding into the shoulder pain, so on and so forth. So I just want to make that distinction. I think it's clear in the article. Sometimes people get caught up in that. So when I say dial shouldn't exist, I mean for shoulder special tests related to rotator cuff shoulder pain, and it's really because that foundation on which it used to sit that we thought was true, and certainly want to give credit to the people who did all that work, right? Those were the men in the arena, if you like that Roosevelt quote, which I do, among with many of his others. They were the ones with the blood on their face. They are the ones in the trenches doing the work there. And so I'm not taking any of their credit away. I'm just saying it's evolved since then, right? Now I'm that man in the arena, and I'm doing what I'm supposed to do. Maybe some years now, somebody will come back and do the same thing. Good on them. More power to them. I'll help you if you need it. Because we're all after the same thing, and that's to benefit our patients if we stay on track. But I don't think because of that flawed foundation on which they were initially set is gone. I don't think we can really take too much into that. Now, here's what a special test, if you want to call it that, might look like, is that they say, I've got pain reaching up in the cabinet, or I've got pain reaching behind my back, or I've got pain, pouring the coffee. That's your special test right there. It's unique to the patient. It's pain provoking. It happens in their shoulder, and you can test and retest that, right? That gives you a little bit more than a special test, but that's your asterisk sign, right? It doesn't need to go much further than that. I don't need to pour make it an empty can and fill the can back up and then, all the way up here. And, if your shoulder hurts, you give me somebody with their shoulder that hurts, and I run through every special test depending on what order I run them in, and I'm going to show you a myriad of positives just because they're shoulder sensitive at that point in time.
Dr. Salamh, I'm a first year PT student, and I only had like a semester and a half under my belt, really, because summer was kind of an easy in semester. So I've only really encountered a couple of special tests, like more related to muscle length this semester. But I know a lot of this other stuff is coming down the road. So reading this, I'm like, okay, like it's good to know, like it's good to anticipate this kind of stuff and how to frame it. But I guess to someone who hasn't been exposed to this stuff yet and will be exposed to it, how would you recommend approaching learning this stuff? Because I don't want to like completely write it off and be like, all right, like I'll learn it, spit it out, and then I'll forget about it completely and never come back to it. But I also don't want to like obviously take it as dogma too. So how would you approach that?
I would suggest, so first, thanks for putting it out there. Continue on. Don't give up after the first semester. I know it can be rough. I'm kidding. You're not anticipating doing that. I get it. But that's a very good question, because, you know, I think as we approach anything in life that we feel strongly about, you know, if you read Sun Tzu's Art of War or anything like that, if I've got an argument, I had better know my counterpart's argument better than mine. That's debate team 101, right? And so I want to know everything and anything I can. I soak it in, you know, take it all in, learn what you can from whoever you can, but you've got to be smart enough to put it through your critical thinking process ringer and see what it looks like on the other end. And then take that, and that's what you put into application, right? So you're taking in everything you can, and then you say, okay, let me sift through the shit, and here's what matters, and that's what I'm going to then apply to my clinical practice, right? And here's the beautiful thing of that. That's going to change. So you don't stop learning. You don't stay entrenched in what you were taught in school. Even that stuff that came out of that critical thinking ringer that you then take forward, that's subject to change. That's like a ... Everything is, right? Because we're going to continue to evolve in our practice. Now, if you look at the statistics, health-related research takes about 13 years to come into clinical practice after it's published. Holy crap, first of all. And then of that, only 30% of it roughly gets retained. Why do I do so much research? Right? You know, it's one of those things that just boggles the mind when you look at those statistics. But it's because of those 30%, those people who are good consumers of the evidence and can sift through that, they're going to help their patients. And if they help their patients and they have students and they're able to teach them to critically think and appraise the literature, you know, golly, then it's so worth it, right? And to take a step back, this is one pillar of the three pillars that hold up what we think of with evidence-based practice or evidence-based medicine or whatever you talk about, right? It's this research pillar. It's what the patient brings to the table and their experiences. That's the other pillar. And then the last pillar is your experience as a clinician, right? So what I tell my students is, unfortunately, you really don't have two of those pillars yet because you haven't been out to build them. So what I've got to give you are my two pillars, which I'm an N of one, so sorry about that, but you're getting my two pillars of my experience and my patient experience. But what I can give you that I know is there is our current evidence, right? And I'd like to think that I can critically look through some of that and give you the valuable pieces of it and then move forward. You know, that's why the scientific method was developed. I had a student the other day ask me about, you know, we were talking about, you know, physical performance test, FMS, and this and that and the other thing. And do you believe in this? Do you believe in that? It's like, it's not a religion. It's not that I don't believe in it or I do believe in it. It's a matter of, if there's supporting evidence from all three of those pillars to buy into it and show me that it works, boom, I'm in. Go for it, right? But you can't have your experience N of one, the patient's experience, which always changes, right? That's sort of what you tailor to, is that patient pillar. But the evidence pillar changes too, but it's a rigorous process. It's more than an N of one. Hopefully, if it's good research, it's quality assessed. You've got a good patient population and you have more than one paper out there. So that's what puts all those other things to the test, if you will. So I don't want to say one pillar stronger than the other. They're all very important, but they're going to change as you develop as a clinician. If I talk too much, just stop me, tell me to shut up. I tend to ramble when we talk about shoulder, and I get passionate about patients and students. And so forgive me if that happens. Just kind of do whatever and I'll shut up and somebody else can ask a question.
That was great. That was a great soapbox.
That was awesome. Like that was super helpful, honestly. Like helps.
I just
frame.
walk on soapboxes all day. I'm sorry.
Not a bad thing to walk on.
Okay, it is actually.
No, that was very helpful, just to kind of frame the context of the journey ahead, I guess. It's we want to reach that point of certainty right away of like, I know what I'm doing exactly. I know I'm going to be right like 90% of the time, but that's just not the case. And like the framing of like the pillars and like I'm getting different perspectives even from my professors from their experiences and stuff. But like I guess framing that not as dogma or as like this is the only way it's going to be from now on, because humans change and adapt and it's such a fluid process. So that was super, super helpful.
Cool. Yeah, I told my wife this morning I was really excited about talking with you guys because there was going to be a lot of students on here, and I knew it was going to be less about this piece of paper that I wrote and more about what we're talking about, right? Sort of the things that kind of feed into that. But it's, this is all, it's more about this, just me and Jeremy putting this paper out saying don't do special tests. There's a bigger conversation to be had, and it's being had, and this validates, if I just had this conversation after writing this paper and nobody else read it, I would consider it a win, because this is what I value. You guys are going to be out there, you're going to be on the front lines, and to be thinking like you guys are thinking with the questions you're asking, it's just, I love it.
Do you see that like one of the issues with a lot of the things that we talk about or question with research is more not necessarily like the special tests themselves, but the context and the narratives that surround them? Because I know like with some of the exercises in chiropractic school that they promote as being like the big thing is, well, I'm not saying that the exercise can't benefit somebody, but it's more the context and the narrative that surrounds the exercise itself and why you're doing it. Because I mean, like you said, if it's more of a pain provocation and you don't really know necessarily how to do that in an organized manner, if you used orthopedics as your way of doing more pain provocation just to see how they're moving, but you give a proper narrative and context, so you're not looking for like specific tissue or damage or things like that, I mean, would these still be considered inappropriate, or could you still utilize them like positively in practice?
So let me see if I smell what you're stepping in here. So you're saying if the narrative changes with how you educate the patient, how you promote your exercises, how you talk to them, can I still use special tests if I changed all the other things I do and how I do it?
Yes.
Yeah. And I'm going to say you can do whatever you want. But I don't think what you'll find is your narrative gives no rationale for the performance of special tests, if that's your narrative, right? Mm-hmm. You'll be saying one thing and doing another, would be my impression of it. And that's so, and these are all good questions, and some of you may be playing devil's advocate, some of you may be coming at me from different angles, and that's great. But here's what I see too is that there's this desire to hold on to these special tests in some form or fashion, right? Can we restructure it? If the framework's that, can we establish this? No, if you build a house on the sand and it falls down, you don't try and build the house on the same, you go to another foundation and you build it differently, right? You build it on a stronger foundation that's going to last. And in my mind, with the current evidence we have, that foundation is gone, and everything that sits on top of it falls on top of it as well. And then, so I guess I liken that to, when we were writing this, we kind of broke down all that and everything fell. And then that table was kind of our resurrection of what it looks like without the special test based on current evidence. And that's probably, to be honest with you, it's probably not much different than what you guys are learning and what's in that box. There might be a few things, maybe you haven't heard of the shared decision-making process, or maybe there's a different way to think about something. But just because we remove the special test doesn't mean that there isn't still a whole lot of solid stuff to that exam.
That table seems like it could be extrapolated to any assessment besides just.
Yeah, it could. And I think it's, I think what you're looking at there is if you, and I think I know we reference it in this paper, is the the article that was published in the British Journal of Sports Medicine on sort of the 11 principles of a musculoskeletal exam, right? And it kind of goes through, and it's based on the current evidence, right? It says, you know, if imaging is necessary, but, you know, we don't perseverate on the results, and, you know, the manual therapy or the passive treatment, it may be okay or helpful in certain circumstances, but it's not the end all be all, and we don't keep doing it, right? But nowhere in there is anything about special tests. It looks very much like that table. You're exactly right.
I guess kind of going off your comment earlier on that, Dr. Salamh, of like the foundation kind of crumble at this point based on what the evidence saying, kind of play devil's advocate. Did that foundation ever stand? And if it did, why? Did people like stand to benefit from that? And like, are there people still out there that you think may stand to benefit from special tests? I know you touched on this a little bit earlier, but I kind of wanted you to dive deeper into that idea of like, I don't know, like this seemed to have worked in the past. And like what about it made it change, I guess? And is there still some kind of patients that can stand to benefit from special tests?
Yeah. Okay. No, that's a great question. So you're looking at, I don't know, I always repeat questions because I guess I'm just used to teaching and maybe you can't hear someone on the side of the room, whatever. So, and it gives you a sense of, am I paraphrasing what you said? Stop me if I'm not. So why did that foundation stand so strong up until this point and benefit potentially so many people? And are there still people with shoulder pain that these special tests may benefit? Is that kind of the gist? Yeah.
Yes. Yep.
So I think it's worked. Well, let's start with the first question, is why that foundation stood and sort of was utilized for so long. Because we didn't know any different, right? We didn't know that, or we didn't appreciate maybe that pain may not just be a nociceptive response to something, that someone's pain experience can be tied up in all kinds of different things, right? And I think it also kind of had this old adage that we used to look at the human body as a piece of machinery or a car, right? Where if there's a piece that's broken or a piece that's worn down or a piece that needs replaced, then that's the source of the pain dysfunction. And so let's go ahead and replace that and they'll get better, right? Well, I'm here to tell you folks, we're not a car. We don't have a check engine light, and it's not that easy, right? We can't just hook up that little diagnostic thing like they do in the garage, tell you what's wrong and fix it, and then charge you, 3 times the amount for labor as they did for the part, or more, depending. Hey, they got to make a buck too. So I think what I'm getting at is that there used to be this idea that we relied heavily on a mechanical source of pain, a biomechanical. There's a tear, there's a whatever, and it needs to be fixed. First of all, you're buying into one, that tear is the source of pain. I call BS on that for a number of different reasons. And that there can't be anything else that's causing that pain, or if it is, it's based off of that origin, right? Well, then tell me why in that Borelli study, 123 people had an MRI of both shoulders, they're symptomatic and asymptomatic, and there was no significant difference except for extreme OA and large cuff tears, but that was only like 10%. So why, if it's a source of pain, it's the mechanical problem that's a pain, why do so many people have that mechanical deficit but have no pain? Well, I would guess that it's not that structure then that's causing the pain, at least in every case. And then you look, holy smokes, let's look at impingement, right? Where you do subacromial decompression surgeries and you go in and there's placebo trials that are done, meaning you have the scope done, you think you had surgery, but they didn't touch anything. And then people really have the surgery and we look a year out and you have no difference in pain, function, range of motion. Whoa, was it the structure that you fixed in the surgery? Because if it was, then explain to me why the people who didn't have that structure changed had the same result, right? In my mind, in some of these cases, we talk about the shoulder, right? Shoulder gets overutilized. Things get inflamed, bursa, cut, whatever it might be. Shoulder is hot, needs to calm down. Let's let it rest a little bit and progressively load it, right? Begin to work up, load, increase function, increase strength, increase endurance, all those beautiful things, tailor it to the patient if that's what they desire. so on and so forth. Kind of sounds like what you do with people after surgery. There's a period of immobilization, they get to rest, you slowly improve their range of motion, their strength. So is it really the surgery, or is it the chance that they get to calm the shoulder down and then progressively load the shoulder after that? I don't know. It's just, that's a hypothesis, right? But I think it stood for so long because everybody bought into that mechanical. It's the mechanical. It's the labral tear. It's the cuff tear. It's this or that. So that's where I think it's perpetuated, and it's still perpetuated, right? I think it's still, I would say a majority of folks still kind of buy into a lot of that. But we have a lot of evidence to suggest, I mean, placebo surgery trials, are you kidding me? It doesn't get much more evident than that. I mean, that's solid work on those folks' part. I mean, hats off to all of them. And so when you ask, is there a particular population that it might benefit? When I think about the shoulder, one, I don't think so for reasons we talked about before. And even if it did, how would we identify those folks would be my next question. And I think, I don't know that you can, because I think it's a fool's errand to go look for a structure in the shoulder that we think is causing pain because of how interwoven all the structures are, the bursa, the number of bursa, how innervated they are with nociceptive properties, and that you know, it's really hard to identify what the source of pain is. And dare I insert other joints, shoulder, knee, right? We're seeing evidence come up in other places. I don't know if you read, somebody wrote a letter into the editor about our paper, and then we were able to quickly rebuttal, and they said, you know, well, if this is the case, shouldn't we question all special tests for like the knee and stuff based on the current evidence? And we were like, yeah, we probably should, right? So thanks for that. I mean, it's a good point, right? So yeah, I think that's the reason why, and people hold on to it. I could speculate and go into a longer tangent about why other outside elements might continue to feed into that. But I think we can all agree that the idea of pain and pain perception is being studied more and more heavily now than it has before, because we're starting to recognize some of those other factors that feed into someone's pain experience.
Dr. Salamh, is there someone else going to ask?
It's all you.
All right. And I don't know how much like practice you currently do, especially like in faculty role, but have you experienced like any sort of, or heard of any sort of pushback when like trying to communicate to patients, like the aspect of like how little we know, like being so specific with the shoulder? Like, do you ever find that like kind of weird spot where it's like, we don't really know exactly, but they find benefit from someone else who told them that it was one specific area? Does that question make sense? Or should I try to
Yeah, no, I think what you're getting at, and we get this question a lot with this, right, is that are we doing our patients a disservice because we're not showing them that we're a credible source of information, or that we don't know what's going on? And if they can't trust us with coming up with that, how in the world are they going to trust us with developing a treatment plan, buy in, and so on and so forth? Is that?
Yeah, that's kind of what I'm asking. And I'm okay with the idea of like not knowing, like I'm comfortable with that, but like more so from like the patient perspective is kind of, so yes, I think you're correct.
No, exactly. And I'm really glad you're comfortable with not knowing. I mean, that's the world, right? And I think the more comfortable we become with that, the better off we are, because there's a lot more that we don't know than we do. And yes, it is very, very important to validate what the patient is there seeing you for, right? And you mentioned they may have seen another healthcare provider who gave them a diagnosis, and maybe it was a mechanical diagnosis, right? Maybe they were told that, wow, this looks like a cuff tear, and sure enough, we're going to get you an MRI, and holy smokes, yeah, there's a cuff tear, and we're going to send you to PT. And it could be, I've heard it all kinds of different ways. It could be, we're going to send you to PT. A majority of my patients do great with PT and never need surgery. And I've also heard, you got a tear, we're going to try surgery. Your insurance company requires us to show that we've tried conservative treatment before surgery. Yeah, that I couldn't be any more behind the eight ball when the patient comes to see me. in that case, right? And I have literally been walking back to the exam room and had patients say, I was told I had a cuff tear. What's PT going to do to fix that? And my answer is nothing. You know, if your cuff's torn, we're not going to do anything to fix your cuff. But we also don't know that your cuff tear is causing pain. And we also know that you're 65 years old. And if you don't have a rotator cuff tear at 65 years old, go play the lottery because you're lucky, right? We know it's a senescent change that happens over time. Our hair gets gray, the rotator cuff gets fatty, infiltrates, becomes devascularized, more susceptible to tear. It happens, right? So we have to be careful in how we present this information to the patient, right? We have to do it in a way that's easily receivable, right? Based on the level we're speaking, right? And we're not going to just throw out papers and grade whatever evidence and, you know, this was a trial and they're like, what? I have no idea what you're talking about, right? But maybe it's, you know, hey, we finished the exam and it looks like you have a painful and weak shoulder. Maybe the weakness is coming from the pain. Who knows? You've got a painful shoulder. Here's why I think it might be painful for you. Maybe it's overused, maybe it's irritated, whatever reason, right? But I'm not going to give a mechanical reason for it. Here's what I think is going on with your shoulder. I think it's irritated. You know, I think you may have overused it. I think it's painful. Whatever, fill in whatever that's not a mechanical piece. And, you know, we have people do very well with conservative treatment. So here's what I'd like to present to you as a treatment option, right, with your permission. And so, you know, that would be how I would go about it. And if they bring those things to the table, you need to, I don't want to say you need to, but I feel like I need to validate them and say, absolutely, you know, but we also find that, you know, professional baseball pitchers, 70 to 80% of them have labral tears in their shoulder on MRI, but have no pain and can pitch a ball 90 plus miles an hour. So, you know, we don't know that that's what's causing. We're gonna go ahead and work through this together and develop a plan and so on and so forth. So I think there's ways to have that, and that may not be easy, right? Particularly one, if you've never done it before, and two, if you're used to providing a particular diagnosis and then working off of that. It can be challenging to have that conversation with a patient. And it's not to say that you won't get some, and pushback's not the right word, but, you know, and you got to be careful too, not to undervalue or discredit the individual who's provided them with that other information, right? I mean, that's not nice. I mean, not that I'm always nice, but that's not, you know, that's not playing well, right? But I'm also not going to hide the truth and what the evidence is just to be nice to somebody else. It's the patient I'm concerned about, right? So, yeah.
Thank you.
Going off of that, if the next step is to gear it more towards activity and exercise and progressively returning back to whatever they want to do, how do you avoid the narrative of like saying that all you need to do is exercise to get stronger or change the tissue structure? Because then that doesn't that do the exact same thing of like what you're trying to avoid?
Right, yeah. And so I think you have to be careful and not only explain to them what you think is going on with their shoulder, but why what you're proposing that they buy into is going to potentially help them get better, right? And so you have to be careful with that. But I do think it's okay to say if your shoulder is painful, it's likely inflamed. So we know that if the shoulder is inflamed and you continue to, you know, work the cuff in a, you know, I think, okay, so let's look at it this way, right? So if you can identify things, movements, weaknesses in certain muscle groups or patterns, right, that you can then develop a treatment plan off of. I'm not saying that's the source of your pain, but I may say that that's something that I found on my examination that I want to improve, right? Maybe it's the endurance of your, you know, your shoulder musculature. I might not even go as far to say as the cuff, because we're learning different things about how the deltoid acts when we get above 100 and some degrees of elevation, and how that helps to stabilize the glenohumeral joint more than what we thought was the primary role of the cuff. And the cuff helps to internal, externally rotate when we get up there, but the deltoid is better suited from a mechanical position to help, maintain that stability within the glenohumeral joint. So we're finding out more and more of these things. So, it's not that I'm providing some vague, superficial narrative to my patient at the end of it, but I'm taking what we found during the examination and we're going to work off that. But I'm also careful of, when you say about, the tissue response and this and that, we can talk about those things because those are physiological changes that we know happen with training, right? But I'm not saying it's tied to your pain, right, necessarily, right? It may be contributing to some of this, but this is what I found during your examination, but I'm not going off of a radiograph or an MRI or a CT scan and saying that that's the source of your pain, because we know that's not true. But I think it is fair to say that if we see a shoulder that, is weak and we strengthen it, it gets better potentially, right? There's evidence to support that. There isn't evidence to support treating a structural problem from just that standpoint alone, if that makes sense. That's a great question. That really makes me think about how I take the information from my physical exam with the patient, which is very little of my exam, if I'm honest with you. It's mostly subjective. How I take that information and then translate it into the treatment, that's not the hard part. It's what you're talking about. It's how do you make sense of that without buying into more of that mechanical piece.
Dr. Salamh.
Go for it.
Awesome, thank you. I had a quick question for you. If you take away the structural classification that many of us have been traditionally taught, is there a substitute that you have or that you go to replace that? Like you mentioned, the painful weak shoulder, the irritated shoulder, the inflamed shoulder, things like that.
I think you can look at a few things, and there's some different classifications, and there's some that are out there, and so I can give you a few, none of which I'd say that I subscribe to on a weekly basis. But you think about this idea, and remember, let's not lose sight of what we're talking about. We're talking about rotator cuff related shoulder pain, right? So we're talking about the things that fall underneath that. So that would be something different than how a stiff shoulder would present, a frozen shoulder potentially, right? Or hypomobile shoulder. That would present differently than a hypermobile shoulder, one that's moving around too much, or the capsule's not providing the check range or the musculatures or whatever, right? So you got the stiff shoulder, you've got the shoulder that's moving a bit more than what we might hope. You've got the shoulder we might throw into this rotator cuff related shoulder pain, which encapsulates a lot of things, right? It's painful, but it's functional, but it might be weak, and this, that, and the other thing. And then you've got those other pieces of, distal clavicle, separation, or glenohumeral joint dislocation, or glenohumeral joint OA, but that falls under a stiff shoulder. And so, if you look at like sort of traumatic stuff, rotator cuff related shoulder pain, stiff shoulders, and hypermobile shoulders, those are kind of some buckets that I think you can easily kind of make sense of, that have different things that fit underneath them, but also have flaws within them as well, right? You can look at treatment-based classification system, which is pain, mobility, and strength, right? And you kind of prioritize what that is. That's not a perfect system either, and so there's elements probably of each of those in someone. It's just a matter to what degree. And I think, and it's not that I don't like classification systems. I think sometimes what it can do is it can give us a nice, comfortable structure to check a box and then guide us down a treatment process. And it can take away from the critical thinking that I try and develop in my students and myself. Because we see something, we say, okay, well, this is, it's like those systems that are out there that, if the patient presents like this, they're in this box. And if not, they're in this box and in this box. And if they're in that box, this is how we're going to treat them. And then they're going to get better, but maybe only 70% of the time. But isn't 70% of the time better than 50% of the time? Yeah, but it's not as much as I'd like them to get better, right? So, and what happens is then if a patient doesn't fit in a box and you don't have a place to, you're gonna force them into a box, right? And nobody likes to be forced into a box. That's mean. So yeah, I would say there's some of those systems out there, and maybe in my head that's how I kind of think through it when a patient comes to see me, right? You start with these hypotheses, you go through your subjective and you can, okay, I'm gonna kind of sort some out. I got a few up here now based on what they're telling me. We go through the subjective, and then I'm like, okay, maybe I've got an idea of maybe two of the things I'm going to focus on, or what I think might be going on. And then I go through my physical exam. I'm like, okay, yeah, maybe now I've been able to discern between, the stiff shoulder versus the rotator cuff related shoulder pain, because I see that their active range of motion and passive range of motion are restricted pretty much the same. It's less than 50% of the other side. It's restricted in external rotation. The radiographs are negative, meaning there's no other structure, as far as, there's no OA, there's no fracture, there's no osteosarcoma that's limiting the range of motion. Then I can say, okay, maybe now I'm looking at something like a frozen shoulder or a stiff shoulder. And so it can be helpful, but I guess I'm just saying, just be careful. That's a changing, that target is moving and the target is changing consistently. And if you're getting more confused as we talk, I apologize. I am too. This is a good conversation.
Alec had a question on the chat. What expectations?
Oh, sorry, Alec.
No worries, you just did it. What expectations do you recommend setting during the eval as they mainly pertain to prognosis, length of time, nonlinearity of rehab, amount of improvement to expect, etc.?
Cool. Yeah, that's a lot of stuff to talk about, isn't it? Yeah. So what expectations do you recommend? Okay. So I think, are you talking about physical therapy treatment particularly, or are you just talking about in general? Would be my question back at you. That lets me think about an answer to your question.
Sorry, I'm doing laundry. I didn't think y'all wanted
That's
to
okay.
watch that. So
Are you folding it
my camera
like nice and proper? All right, good.
I am, yes. Just in general, I think a lot of times we hear recommendation to like set expectations up front about like, what the patient can expect to get out of PT, not promising the world, like saying they're going to be completely pain-free or that sort of thing. And I guess this can probably differ from case to case, but just like any general recommendations you have, or like what to expect, if we should be setting expectations about pain or just like kind of talking about, let's try to get this stronger and see, what kind of improvements we can make.
Yeah. So, good question. So I think we look at this when we talk to the patient about their expectations. This is maybe after we've had that shared decision-making conversation with them, right? So the shared decision-making conversation goes a little something like this. You've done your exam, you've talked to them about what you think is going on, and then you present the options that are on the table for them, with no treatment always being an option, right? So here's what's going on with your shoulder. You can opt for no treatment. Here's what we know from our experience that happens with someone like you if you don't do treatment. Okay, that's an option. Physio is an option. Here's what the evidence says we know about folks like you if we treat you or don't treat you, right? And that's what we know. Here's the evidence to support or refute surgical intervention, right? That's an option, and so, and some people say, whoa, aren't you kind of overstepping the boundary there? You're a PT and you talk about surgery. No. I'm talking about the evidence, which I'm very, very qualified to talk about. And I'm letting you know that the current state of the evidence supports or refutes this type of treatment for these reasons, period, end of sentence, right? But then it's the patient who gets to make that decision. It's the patient who decides what treatment they would opt into. It's not, if you don't have that conversation with your patient at the end of the treatment session, I'm going to be honest with you, I didn't up until, I don't know, maybe a year ago, right? But the more I listen to my good friend and mentor, Jeremy Lewis, I kind of try and emulate him along with other people because they're smarter than me. And, he wrote a paper along with some other folks about this shared decision-making model. So, okay, well, that makes really good sense. I really haven't allowed my patients to make that decision. We've had the discussion, right? You know, they're there to see me, and then basically just telling them, here's what we're going to do, right? You know, or you might be saying, okay, are you okay with that? Are you okay with this? Or, you know, does this sound like a reasonable treatment plan? And most folks are going to say yes, right? But I'm not giving them any information about no treatment or other options or opening the door for them to think about other things. I'm just pushing my PT because I'm a PT. And when I sat back and looked at that, I thought, oh, geez, that seems kind of arrogant, doesn't it? To think that I'm the only option that they've got, when in fact they've got other options too. And it's their choice. And it's certainly going to benefit me more if they want me to intervene versus if they don't, right? And we can have that honest conversation. And so if they say, yeah, PT sounds like a great option, I was like, that's great because I'm one of them. So let's get to work because you're already here. And so, you know, you got to set the stage for whatever it is that you think is going to be real heading into the next, I don't know, 10, 12 weeks, right? This isn't we're going to try 3 weeks of physical therapy, and if your shoulder's not better, you're going to get surgery. That is a horrible chance for PT to work, to be honest with you. It really is. I don't know how else to put it. It's not a fair shake at physio to say in 3 or 4 weeks your shoulder is going to be at a place where I've exceeded your expectations and you can do what you want to do again. I'm not a friggin' magician, right? So I've got to be honest with the length of time. I've got to be honest with how I think your shoulder is going to feel and what I expect your shoulder to feel like. Is it okay to have a little pain when you're exercising? Okay, yeah. But I don't want it to feel like this. I don't want you not to be able to use your shoulder the next day and you think that's a good thing because you worked it hard the day before. So, no, we got to have that conversation. We don't know their mentality unless we talk to them about that, right? And I'm sure you may be some of those people. If not, you might have met some of those people who, you know, it's always the no pain, no gain thing, right? And so, you know, you've got to kind of either dispel that or tell them how that works or doesn't work in this current state of rehab that they're buying into. And then I think you alluded to this, so I'm just going to extrapolate, and that is the fact that your progress is not going to go like this. It's going to be like this. You're going to see days where it doesn't feel so great. You're going to see days where it gets better. The overall trajectory, when we sit down and recall it, those should be heading in a positive direction. And if it doesn't, over 11, 12 weeks, and we tried all kinds of strategies, then we can say, okay, we gave it a good shot. Here's where we sit now. Here are maybe some other alternatives at this point in time, because that decision process is different because you've already given a real good shot at physio, right? And so I can't give you a sort of a sheet that outlines every aspect there for what you're going to tell your patient, but I can tell you, the more transparent and upfront and honest you are with them, the better it's going to go for both of you. And again, these are all just life lessons. I think that's what we're talking about here, right? So just be honest and upfront and transparent. And if you foresee something happening, God, wouldn't it be nice to know before it happens? So you say, what? Geez, you told me that was going to happen, and it did. Wow, there's a little bit of credibility there, right? Well, you never told me that my shoulder was going to feel like this after or X, Y, and Z. Let them know what the possibilities are, and so they have a good sense of what may be to come.
Off of the shared decision-making conversation, I was re-listening to the Insights podcast with you and Dr. Lewis, and he had mentioned the manual therapy kind of briefly at the end in regards to if a patient expects it or if they've had it in the past. Who's to say that they shouldn't get that? But if we extrapolate that out to right, like any passive modality or anything that maybe we may not feel is the most efficacious for them at the moment, what are your thoughts with just because they expect it or want it, how much do we give into that just because it's that shared decision-making process?
Yeah, tricky, isn't it? That's a tricky little thing. And that's a great question. And I think, you know, I'm going to kind of go where I think he was going because I've heard him talk about it before, is that, we would be foolish to sort of discredit what they're telling us, right? That worked for them. But we also need to be upfront with them that that's probably not what's going to get you where you need to be, right? And here's the beautiful thing. If it was for the same problem, then you've got the ammunition to throw down to say, you had that done before, it worked for you, but you're here again for the same problem. So maybe now we'll try something different, right? Not that that was a bad idea, but it worked. Maybe it was temporary, maybe it helped a little bit, but we're going to try some other things. Or maybe we can do that as an adjunct a little bit to pacify you if you feel like that's going to help get that buy-in, or if it's going to do the other thing and create a wedge if you don't provide it. Because again, it's about validating what they're saying, but also kind of sticking to your guns and what you know might be the most efficacious for them at this time, right? And so I've run into that gobs and gobs and gobs of time, right? And God forbid you got someone who couldn't see the therapist they wanted to. Oh, I have to see you today, Paul. I'm sorry about your luck that your other therapist wasn't available. I'm gonna pinch hit for him today, and you can go back to him if you want. That's up to you. But if the therapist in the same clinic did, treatment, they did it all the time that I wouldn't do as my treatment, then that's a whole nother layer, right? Because I don't want to piss off, my colleague, but at the same time, how much do I care about my colleague versus my patient? And shouldn't we care about everybody and sing Kumbaya over campfire every night? Yeah, great. But, at some point you've got to be willing to stick to your guns, but validate the patient. And that's a fine line to walk. And sometimes comes with experience.
To feed off of that, at what point, if at all, with this demographic that we're talking about, would you recommend or look into more of the invasive options? So, I mean, if you have been working with somebody for an extensive period of time and it just doesn't seem to be improving the way that you would like, if at all, are you going to recommend or have that conversation about more of the invasive options? Or are you going to try and continue to promote what you've been doing? Like, how would you approach that?
Yeah, I don't think I would continue to promote spinning our wheels together, hoping for the same outcome. Now, if I mucked it up somewhere along the line and, my thought process wasn't right and I was heading down the wrong trail, right, then I hope I'm cognizant enough of that to realize it sooner rather than later, and to admit to myself, oh crap, I'm probably not heading down the direction that, and that happens to be on the daily, right? So then you start heading back and give yourself a good, but not every patient's going to respond to that for all kinds of reasons, right? One being, if you think surgery is going to help your shoulder and I'm offering you something that's not surgery, chances are it's not going to help your shoulder. And at the end of the day, if I'm sitting here telling you I'm more concerned about my patient than anything else, and I want them to feel better, if I've exhausted what I have to give them and I feel like I've given them the best of what I've got, then it's only right, based on everything we've said during this conversation, for me to have the humility to say, we both gave it our best shot. Let's look at alternative options at this point in time, right? And that's, and don't misconstrue what I'm saying. I'm not saying that no one should ever have shoulder surgery ever in their life. I've had shoulder surgery on my shoulder, happened to muck it up and whatever, but I'm not bitter. There's a time and a place for it. And I think that would probably be a decent time and place to consider, right? And not because all of a sudden it's changed my mind that, there's now a mechanical thing that's causing pain or this or that. No, it's because I've given it my best shot for what I know I have to do. And I recognize that, I have my limits, just like every other person has their limits. And so now we've got to consider something else. And I've got to be willing to do that in order for the best interest of my patient. You think less of me now? Well, you probably didn't think much of me anyhow, but anyhow, go ahead.
No, I appreciate it. Thank you.
On a I guess this is more of a meta question, but transitioning from Duke to University of Indianapolis, you told me prior to people getting on that obviously Duke's very research heavy, is like kind of the number one goal within the program, and then Indy is more teaching heavy or focused, right? Does the teaching, I'm assuming you do more of it, has it been hard to transition, and do you feel like you're creating more or less or the same of like an impact that you were hoping if you're not doing as much heavy research compared to Duke?
Yeah, and if I'm honest with you, I'm still trying to do. I'm probably doing more research now than I was when I was at Duke. I just have to be careful of how I do it, right? Because I do like to sleep, and I have a family, and I like to spend time with them. So early on, I've learned how to establish boundaries, but I've also learned mainly through my faculty residency how to work smarter, not harder, how to say no to a lot of things, and so all those things and a bunch of other stuff has allowed me to still teach at the level that University of Indianapolis wants me to teach and maintain a very active, at least I think for myself, an active research agenda. And so, but when I put the two together, when I talk about the evidence in front of my students, holy smokes, like I'm off the ground most of the lecture. I'm elevating just because I'm so friggin' excited to be able to talk about those things and have the ability to do that in front of my students. It may be a little unconventional the way I go about it, because I like to create a little discourse because they're aware of these things, right? They're aware of the special tests. They're aware of the mechanical diagnoses. And so I have to provide an environment where they feel comfortable enough as learning clinicians to have what they need and be confident and not go out on a rotation and feel unarmed, if you will. So it's challenging, but I think anything worth doing is, right? So.
Do you think it's been hard for the students you teach to grasp the concept of kind of the uncertainty of the maybe examining the shoulder and not being able to tell like which tissue it is or what's the exact diagnosis, or are they? Yeah.
I think it is for some, and I think for others they understand, right? Just like anything else. I think it makes sense to some of them, and I think others, and by no fault of their own, it's just that they kind of crave that diagnosis to be able to then deposit a particular treatment. So I'll intentionally, when we get to our second musculoskeletal core sequence, we review cases, right, where I reveal a little information, we talk about things, and then we kind of work through a case. And so I'll work through one or two cases, and then I'll be able to kind of sense those folks who are a little frustrated from not being able to get a real diagnosis or this or that. And we'll move into the third case, and I'll say, so I can tell you guys, you're hungry for a diagnosis, or you want some kind of diagnosis. Yes, absolutely. Okay. All right. So here's your diagnosis for this patient. So what's your treatment plan? And they're like, well, we haven't done a subjective exam. We haven't done the objective exam. Exactly. Having a diagnosis, doesn't matter whether I give it to you at the beginning of it or the end of it, you're not treating the diagnosis. As much as you would like to think so, you are not. And it's not because I'm, trying to make it a crazy, uncertain nebulous of confusion. It's just that it goes back to these principles of, we don't know that that's the source of pain. So we're not trying to propagate that. And even if I don't know that, I still have plenty of information from my examination to formulate a very good treatment plan without that medical or physical therapy diagnosis, other than you've got shoulder pain, or you've got a stiff shoulder, or you have a hypermobile shoulder, or you just fell on your shoulder and it hurts, and so, getting them to put more value in the pieces of their examination process independently and then cumulatively together to come up with a plan and not base their plan off a diagnosis. Because inevitably, what will happen to some individuals is they will base their treatment plan off of a diagnosis more so than what they found during the examination. And I've seen it happen over and over again in practicals, where I say, where's your evidence from the examination to promote external rotation here like this? Were they a penguin that you found on an iceberg who kind of, or a T-Rex, how functional is that? They can do these things up here. Let's work them where, you know what I mean? So I want to have evidence for my physical examination most of the time, if not majority of the time, to give a rationale for what my treatment is, right? So, and they say, well, I found out that they had this diagnosis, and I know you treat that diagnosis like this. Let's treat the individual in front of you, not the diagnosis that you think they have, right? And so that's kind of where some of that comes in. And I might be completely off my rocker on that, but that's my tendency to want to approach, is to develop the critical thought process and their ability to work through an evaluation and take what they find from that to develop a treatment program instead of based off of a particular diagnosis.
Bert asked in the chat, how do you manage the fact of knowing the reality of special tests versus the need for teaching it for board exams?
Yeah, right.
I'll add on to that.
So that couple, sorry, go ahead.
I was going to say, I'll add on to that, maybe the different teaching of other professors within your university, of what maybe conflicting thoughts.
Yeah, right. That's a lot of pushback like that. You must not care a daggum thing about your students, because if you did, you'd teach them all these special tests so they could perform well on a board exam. Yes, I do really care about a computer-based exam for a hands-on profession. Absolutely, I do. No, I do, in the sense that you need to pass it in order to practice. So my thoughts about the board exam, who cares, right? But at the end of the day, what you need to know to pass those questions is this special test tests for this particular diagnosis, right? And please tell me how in my sequence of the semester I need to fit in teaching 70 plus special tests for the shoulder in addition to the actual stuff that means something, right? So how do I discern which ones to teach, which ones not to teach? I would say, here's a textbook that you are required for this course that has them listed. Feel free to read it on your own. Or any prep book for the exam will also have those listed in there for you to take a look at. But the way I see my role is not to teach you how to pass a board exam, probably the lowest bar that you could set for success of a PT program. That's not my role. My role is to make you a clinician who can think and be a good consumer of everything we've talked about 5, 10, 15 years down the road as things change. I tell my students, if I see you in 10 years in the clinic and you're doing the same thing I talked to you about doing 10 years ago for shoulder individuals, I'm not going to be happy, because I know things are going to change, and you had better be a good consumer of the evidence and not just do what I told you to do because it was what was best to do then, right? So I get a little frustrated with that because, and I contacted the board of examiners as we were writing this, and I said, hey, I know there's still questions on the board exam about special tests. Would you be willing to kind of have a little bit of a dialogue, and we can include you in this paper saying that, we're moving away from that because of current evidence, and it would show evidence in the practice and how the board exam changes for, we had a nice exchange, and they had their own policies and procedures that they go through in order to create the questions. And I completely get that. And I think they need to stick to that. But I'm also not going to water down or change my narrative for an exam when it doesn't fit what current evidence and practice supports. And it's not because I don't care about my students. They still have the resources to study for that. And the people at the board exams were kind enough. They went into the bank. I mean, they didn't show me the questions. They went into the bank and looked at those questions and said, if your students know what the test is and what it tests for, that's really what they need to know. Okay, great. And I liken it to, I've got 3 kids, and if I want to teach them not to smoke, which I do, it's their own choice, but I don't teach them not to smoke by putting a cigarette in their mouth and lighting it for them. That's not how you teach someone not to smoke, right? So why would I teach my students not to use special tests by showing them every special test in the book and say, hey, I don't do these special tests. There's no value. They're fundamentally flawed. And I don't perform in clinic, but I'm going to show you every single one of them so you can pass your board exam. Wouldn't I look like a fool, right? More so than I do on a regular basis. But, you know, so that's kind of my answer to that. Sorry, that's something that's, yeah.
I know personally I get frustrated in our class because they'll teach us those tests, but then if you go to ask them if they use the tests, they get all kinds of pissed off, and they specifically say, don't ask me if I use these. But I'm like, to your point, I mean, if you want to educate us on these, I think it's in my best interest to know if you're actually utilizing them in practice the way that you're educating us on how they're supposed to be used.
Right. And I think that goes back to the transparency piece, right? I mean, I try and create an environment in my class where, and right or wrong, I don't know, this is just where I make myself vulnerable. I'm going to tell you whatever. I'm going to put myself out there in hopes that you reciprocate that and feel comfortable putting your experiences and self out there so we can actually learn something, right? Instead of going through a process or whatever we think we need to check boxes and do whatever. So I don't know, maybe people don't like that.
Should we transition to the decompression paper?
We can do whatever.
Let's do it.
Let's do it.
So this, I'm still confused on like, this was a rapid response, or this was based off of a BMJ rapid response? Could you elaborate on that?
So this was one of, let's see, I think it was 4, but I'm just going to double check. 3 or 4. No, so there were 3, sort of 3 pieces of evidence that kind of led to the rapid recommendation by the British Journal of Sports Medicine or British Medical Journal. So they put out rapid recommendations to help sort of move along things that are critical to know. And there was only one other rapid recommendation that was orthopedic prior to this time. Most of them were around cancer and, you know, HIV and this sort of thing. So it can be anything medical, but it's a rapid recommendation to say, hey, here's our current state of evidence. This could change things. We need to move in another direction. So let's not wait until whatever. But what that adds is another level of, there is a very strict sort of process to go through that. It's not just like, oh, you write a paper and there's a panel and there's people who agree, disagree, and you've got to have supporting evidence. And so we did this systematic review in conjunction with a Cochrane update review. And then there was another clinical practice guideline that went out in addition to this that Claire Arden and some other folks were on. And then all that led to the rapid recommendation for not recommending subacromial decompression surgery anymore. And I think that's summarized in maybe in box 1. Yeah.
Yeah, I was gonna link it. Thanks for clarifying that.
What was the reason for doing like a rapid review as opposed to a non-rapid review, if that makes sense?
Yeah, so it's not like you really choose something like that. It's sort of based on the merit of the work and it's not something we decide to do. Like, it's not like, oh, I'm going to set out to do a rapid recommendation. It's like, I'm going to do this. We're going to submit it. The timing's right. And this panel at the British Medical Journal says, this is something that needs to be, and so we're going to put it under different scrutiny and this and that. So if you read this and it looks different than other systematic reviews, part of that's probably why, you know, we included patients. So there was a panel that talks about the panel and everything that's necessary in order to go through the process to make a rapid recommendation, because it's not just a systematic review that kind of gets put out there willy-nilly, if you will. And I just happen to tag along the coattails of these incredibly smart individuals. Yeah.
The guideline panel, it included the experts, frontline clinicians, methodologists, and then 4 patients. How did that, like, why is 4 the number?
I'm not sure where those, so now we used more patients for our review, if you look at that, I think there was like 30 some patients who weighed in on what was important to include on the systematic review and things like that, which is a great thing, right? All this work we ever do, and we never bother to ask the patient's opinion, but they're the ones we're doing all this work for. So isn't that a novel idea? But I think it's part of the panel, and it's not like they bring in a ton of people from any of those methodologists or clinicians, this or that. It's that they bring in valuable people from each of those perspectives to provide that individual's perspective as they're going through that process of reviewing it for a rapid recommendation. So I have no idea where that came from. That was probably the panel that formed that, would be my guess.
Reading this paper and just the subacromial decompression in general, so we just finished our shoulder module for MSK, and a lot of it was like either a primary or secondary impingement kind of narrative the whole class. And looking at the decompression side of things, it's like, well, if you can't go in and structurally change, well, you can, but it doesn't provide lasting outcomes. Why do you think a manual intervention or even an exercise intervention is going to create long-lasting subacromial space if a decompressing surgery is not even going to, if that's not going to help with long-term outcomes? So I like this because I feel like it provides a much stronger argument for the impingement side of things, and if we can actually change that without surgery, and if it even matters.
Yeah, and then the fact that impingement doesn't even really exist, there's that too. And so, and I think Jeremy Lewis has kind of done a good job both in Viewpoints and other research to really kind of hit that point home. And it talks a little bit about in here that it was a theory by Neer, and it's always been a theory. It's never been proven until we do these placebo surgeries, and it gets proven to not be true, right? But there's a lot of evidence leading up to that. If you kind of read the writing on the wall as you go along and look at, if that's the case, you think about the subacromial space, and it's not that things don't touch, but they don't impinge. And interesting, Jeremy was just interviewed on it was a frozen shoulder thing, and impingement was brought up in there, and he's like, well, don't get me started on that. Things don't impinge. They might touch a little bit, but impingement doesn't really happen. Even with those, the different shapes of acromion and this, that, the other thing. When you look at that, the theory is, and holy smokes, did I buy into this heavy for many, many years, right? And I'd bring out the model in front of my patients, and I say, your humerus is riding high, and it's what lives in there is the supraspinatus tendon. And man, if you have a bone spur in there and the thing rides, man, just imagine the pain, and that's why your shoulder is bothering you, right? And I would sell that like a used car. I'd wear the tie and everything, and it was a mainstay of my clinical practice because that's what I bought into. That's what I believed. It's not necessarily what I believe now, and based on current evidence. We see study over study over study again that shows that when that supraspinatus does begin to tear, more often than not, like 70 plus or minus %, depending on what study you read, even with oddly shaped acromions, happens on the articular side of that tendon, not the tendon part that lives next to the acromion. It's the part of the tendon that lives next to the glenohumeral joint. So it's not getting impinging there and tearing. So that's kind of where things began to unravel, if you will, for this idea and this theory that Neer presented back in the 70s, I believe, about impingement. And then, people were thinking, yeah, okay. And this is a big debate among surgeons. Most of these people on here are either physicians or orthopedic surgeons on this paper. And they get a lot of flack. There's sort of a divided group of individuals that say, subacromial decompression surgery helps my patients. And they're like, well, the placebo trials say that it doesn't now, right? And then you've got the FIMPACT trial that just, recently was published and all that stuff. And so, the argument goes back to the people who think it is helpful is that they see good outcomes in patients who have that surgery. But part of that may be because of what we talked about earlier, right? That's sort of letting the shoulder calm down and progressively loading it. And that's why we don't see a difference between, conservative treatment versus, placebo, or placebo versus surgery and that sort of thing. Because if it truly is just the structure, if it truly is that distal clavicle and maybe some, osteophytes, some of those bone spurs there, then shouldn't that surgery help with that? Yeah, you would think so. But it's interesting. That's a prime example of a theory that's never been proven from the 70s that has cost the healthcare system, people, everybody, tons and tons of money and thousands, if not millions of surgeries based on a theory, which has got to start somewhere, right? But now I think it's time to stop. And that's what this, not just this paper, but the other papers that go along with it and the rapid recommendations say, for these type of individuals, don't do it anymore. Not, oh, we don't think you should, or it's a low recommend. It's a strong recommendation against subacromial decompression surgery. Yeah, who doesn't love the shoulder model, right? Who doesn't love a shoulder model?
Well, Dr. Salamh, I was going to go along that note of, so this was published as well as like multiple other things. That is an absurd hashtag in the chat. But
is that even allowed? Are you allowed to have that many carrots in a hashtag? Many letters? I don't know.
So where I was going with this was, okay, so a lot of different things were published, and the recommendations coming out, stop doing this surgery. And I think there were even some like physician groups were making comments on this as well. And then what actually, I can't remember the name of it, but they looked at like the rates of these surgeries, and until it was the reimbursement changed, there wasn't that much of a change in actual practice. Sure. There was some, but it significantly changed when reimbursement changed. From a systems side of things, when companies, insurance companies, or healthcare models or healthcare companies are looking at changing their reimbursement, how important do you think research is to them making those decisions? Or do you know how they're making those decisions?
I'd like to think it was, it would be very important, but unfortunately, I think I'd be naive to think that, right? Now, I mean, obviously, I can't speak for all insurance companies or all systems around the world, but I do know that money helps to drive some of these decisions, right? And as you mentioned, once reimbursement rates change, then that's interesting. Things begin to kind of change as well. Isn't that a funny little tale? So I don't know off the top of my head how much evidence is considered when looking at reimbursement rates, but I would say it's probably considered more now than it has been, because I've seen examples like what you're talking about, and they point to that, right? And so they'll say, what you would hope. So like the greatest thing for me would be to publish a study on something that I think fundamentally needs to change or whatever, kind of like this. I'm not taking credit for this paper. Like I said, I was a very small part of this. But when you put something out like this, and then that changes policy and that affects things and that lowers the number, that's what you hope for, right? But it doesn't always happen. And so I honestly don't know how much emphasis they put on it, but they've got to be putting some emphasis on it. There recently, a few years back, I don't know if you all call one of this or not, but in Australia, for disectomies, the insurance company said, we're no longer going to be reimbursing orthopedic surgeons for disectomies. Forget it. We're done. And they right, until somehow, somewhere, somebody lobbied for something and money was involved, and now all of a sudden the reimbursement rates have gone back up, but the evidence hasn't changed. If anything, it's become stronger in the same direction. And so, we've got to be also aware of the other factors that influence our healthcare system or model, and whatever that might be. And man, I'd love it to see it be driven by quality gobs of evidence, right? Not one or two papers, but quality evidence over time that shows a trend and is supported, and so on and so forth. But unfortunately, that's not always the case. I think this is something that is hitting home and we'll see some of those changes. But that's like the next step, right? You do something like this, and then how do we advocate for policy change, right? It's written in here that we hope policy and guidelines and stuff look at this and make recommendations and make changes, but that's a hope is what that is. And you know, that would be nice.
So with a patient who's had subacromial decompression surgery and they didn't get the results that they hoped for, as we see it's probably pretty likely, how do you have that conversation with somebody who shows up to your office after this surgery and they're still in pain and they're still miserable? Because we see, like with failed back surgery, where people get stuck in this vicious cycle of surgery after surgery because the surgeons continue to think it's biomechanics, but they come to you and you know that pain is so multifactorial and that there's too many things involved to simply put it on that structure. How would you kind of handle that situation with a patient?
Yeah, that's tough. So you're talking about somebody who's had subacromial decompression, distal clavicle excision, and all that stuff, and then we're 3-4 months out, maybe even less than that, and they're not any better, right? Which I think in the paper, we look at those 1-year outcomes from some of those trials is that there's not a difference, right? But then there's also this group of individuals who have continued pain 1 year out and beyond and aren't satisfied. So that's the group of individuals you're talking about, and that's tough, right? That's probably one of the tougher things that you've got to deal with, because your patient is now dissatisfied. They're angry, they're upset, they're frustrated. They probably took time off of work. Their family's taken time to maybe come in and take care of them, or who knows how many people have invested how much in this individual because of this surgery, and now it hasn't worked. So all of that just compounds, and now you've got a really frustrated patient, and rightfully so. I would be too. I can vividly remember, and this was a patient probably, right, at least 8 years ago now. It's got to be at least 8 years ago when I was in North Carolina in private practice. I can remember it was a young man, and the way this surgery is sort of described to most folks, at least how I've heard surgeons describe it, is, 3 little holes. We go in, we're going to clean this up, we'll clean that up. We'll basically just kind of, clean up the cobwebs and whatnot on your shoulder, sew it up. It's like a 20-minute procedure, and then you're home the next day, and there's really, home that day, and there's really no precautions, right? It's just kind of like pain is your guide and this and that, unless they do a biceps tenotomy or tenodesis, and then that changes things. So I think that's where the expectations get set up of this is a little thing. This is not a big deal, right? And so when it becomes a big deal, now you've got one of the biggest problems you could face as a clinician or as a person doing business with somebody, and those are misaligned expectations, right? Those are, I come into your shop and I'm expecting this, and you've said, yep, this is what's going to happen, or maybe you didn't say anything, and what I get is not it, right? And I'm not happy now because I didn't get what I was promised or what I thought I was going to get, and you weren't upfront with me, or something happened, and now I'm pissed at the world, and you're in the world, and I'm pissed at you, and you didn't even do the surgery. You were trying to help them, right? And you got to maintain the relationship with the surgeon and the patient, and walk lightly and do all these other things. I think the best thing you do is listen, validate what they've got going on, and try and address their impairments as best you can. But the problem at that point, you've done that the whole time, right? And so it's a challenge. There is no easy answer to that. I would think that what might help you is to identify, if you can, that early on, right? So maybe you've seen folks post-op, and this is out of the ordinary. 3-4 weeks have gone by, and this just doesn't smell like what you're used to smelling after this surgery, after this period of time. Better to recognize that early on. Have that conversation with the patient, maybe even the surgeon, and say, hey, this doesn't jive. Recognize it, right? Instead of just spinning your wheels knowing, oh, this does not look good, right? This train's going 100 miles an hour, and there's a car on the tracks, and it can't move. instead of calling anybody I can to help out, I'm just going to stay quiet and see if that train really does hit that car. Guess what? It's going to hit it. Okay. So let's get out ahead of it if we can, and involve the people that are already involved, and have a collective conversation that's in the best interest of the patient. Wouldn't that make you feel better than waiting until that point when all that frustration's built up and say, oh, you could get to the same point, but you might feel a little different at that point if at least people along the way have been kind of scratching their heads and trying to help you through it, maybe some different alternative treatment methods or whatever to help you along the way. So I think maybe if you can recognize that earlier on and then involve the folks in the process in that conversation, that might be helpful. Now, that's a wishy-washy answer, but I don't know that there is a real straightforward answer on that.
All right. Does anyone have any other questions, or we can wrap it up there? Perfect. Dr. Salamh, do you have any final remarks you have for the students of recommendations going forward?
So all I would say is kind of keep doing what you're doing, right? So you're sort of, we've got a selection bias going on here with the group of folks, right? You're smart kids, you're in PT school, you've tuned in to these great conversations with other people, not with me, but you've tuned into previously great conversations because you wanted to learn more and sort of understand the truth and how to better help your patients. And you guys are, I would say, well ahead of the curve. So keep doing what you're doing. Find a good mentor. Be willing to check yourself regularly, no matter how hard that is. And please don't misconstrue anything I've said here to downplay, previous people's work or people who might be trying to teach you something different or some other way to do it. As I mentioned before, learn from them, try and understand their approach. And, but at the end of the day, it's the patient that you're there for. So don't forget that. And I really appreciate you guys have made me think about some things, which is why I love talking to smart students, is because I learn from you guys. And so I really appreciate that. And I appreciate your time. And if you ever have any questions or need anything, feel free to reach out to me, email or telephone call or whatever. I'm always happy to chat with folks.
Awesome. Thank you so much. Maybe next time, if we do this again, you can wear a tank and we can all just,
I know, right?
Bro out.
But it's got to be in summertime. My complexion is horrible. So in summer, I spend a lot of time out by the pool. So that'd be a better time to schedule these things. Maybe we can do a poolside or something.
That'd be great.
Yeah.
I'm just going to talk. Definitely just said next time we can bro out, and I held my own this entire time.
Oh no! Who said bro out? Oh, see, that's awful.
Hannah, the definition of his bro is just a chill person that likes conversation. Females are bros.
I'll bro out. I can bro out.
True story.
Thanks, Hannah. All right.
See,
thanks everyone for joining the party.
I didn't even. Sorry, Hannah. I didn't.
Well, I didn't turn my camera on because I was eating a waffle when we started, and I didn't want to make everyone jealous about my waffle. So then I felt like I'd waited too long to turn my camera on and draw attention, so I just left it. Snack queen, yes, I am the snack queen.
We could write a paper on that, yeah.
All right, solid. Okay, y'all enjoy the rest of the Saturday. Thanks again.
Thank you.
Bye.
Thanks, guys.